Good afternoon, everyone. We'll be starting in a few minutes. We're just opening up the platform to allow all of our participants to join us. Welcome and give us a few minutes. Well, good afternoon again. My name is Al Richmond. I'm Executive Director of Community Campus Partnerships for Health. And I'm based in Raleigh, North Carolina. And I want you to do something special this afternoon. I just want you to take a deep breath because I know that you're so busy attending Zoom webinar series and all kinds of things. And many of you are working at home and some have gone back to work in a real space. And so I want to just encourage you just to breathe this afternoon. It's such a busy time and we are taking in so much information. And so it's important to do just that. I want to welcome you to our webinar series, Communities in Partnership, Ensuring Equity in the Time of COVID-19. It's been such a pleasure for us to join you over the past now 4 months as we have addressed a number of issues associated with COVID-19 and also issues around the disproportionality of COVID-19 as it impacts racial and ethnic communities. As we move forward, I want to, again, to continue to encourage all of you to join CCPH and other nonprofits and community-based organizations and doing our collective work around the U.S. Census. We have been informed, as you know, that the time has been decreased for response to that. And so it's really important for us to actually work within our communities to make sure that we have accurate counting. And so please do your part, join us in that work. This webinar series is hosted by Community Campus Partnerships for Health and the University of North Carolina Center for Health Equity Research. The series is co-sponsored also by the Robert Wood Johnson Foundation Clinical Scholars National Leadership Institute, a national program that is for experienced healthcare providers that is supported by the foundation and is based at the University of North Carolina. We're also excited this afternoon to have a new sponsor for this particular webinar series, UNC Rural, and I'd like to allow our co-facilitator, Dr. Giselle Corby-Smith, to say a word about UNC Rural.
Thank you so much, Al. I am so grateful to be able to be here this afternoon with each of you, or at least it's afternoon in our time zone. Amongst the things that I do at UNC, I'm also Associate Provost for Rural Initiatives and have been responsible for standing up UNC Rural. Our goal with UNC Rural is to really harness the collective strengths that we have in our community and our campus partnerships to foster well-being and vitality in North Carolina's rural communities. And through UNC Rural, we're promoting and strengthening existing partnerships, looking for ways to align community campus partnerships with the needs and interests of rural communities, and connecting new partners and facilitating new partnerships for a thriving North Carolina. And so we are particularly excited to be able to co-sponsor this webinar that's looking specifically at the impact of COVID-19 pandemic in rural communities. Thank you.
Thank you. So the objectives of our webinar series have remained consistent. And as we want to kind of highlight those today, and our objectives are to share diverse perspectives on COVID-19 and its impact on health equity, to develop a network to support systemic changes in response to COVID-19, and then to explore collaborations and partnerships. And you're going to hear examples of that this afternoon in promoting equity and the response to COVID-19. So this afternoon, our focus is on the impact of COVID-19 in rural communities. And I want to kind of frame this as we move forward um, in our conversation this afternoon. So at the onset of the disease in the United States, we heard about the epicenter was New York and other large urban centers. And so COVID-19 has already swept through many of these cities and urban centers. But also with the progression, it began to attack the Sun Belt with a vengeance this past summer, and then shifted its focus to the Midwest. And now the illness appears to be building with rapid speed in rural America. And that's really what prompted us to really want to focus this afternoon on the impact of COVID-19 in rural communities. So for everyone who is living in a rural area, we want to really emphasize that our rural communities are not immune from this virus. And that's critically important that we give attention to that. In fact, there are 13 states where the now confirmed COVID-19 cases have increased in the past 2 weeks. And those include Missouri, Minnesota, Oklahoma, South Dakota, Wyoming, and Nebraska. And there are also 29 other states, largely rural states, where the disease is also having a disproportionate impact. And so while we should all understand that over 46 million Americans live in rural communities, and that those individuals living in rural communities face the distinctive challenges focused around COVID-19, the COVID-19 pandemic. And that includes long-standing health disparities and social inequities. In rural communities, Americans tend to have higher rates of cigarette smoking, hypertension, and obesity. And so it's for that reason that we wanted to give attention this afternoon to COVID-19. So we have two amazing guests this afternoon that are joining us. Our first guest is Allison Owen, who is the Deputy Director of the North Carolina Department of Health and Human Services, the Office of Rural Health. Allison, we've known each other for a number of years, and we've been able to work together on multiple projects. And so we're excited to have you this afternoon to join us and share what the North Carolina Office of Rural Health is doing to address COVID-19.
Thank you, Al. It's a pleasure to be here, and thanks for the opportunity to share a little bit about what we in North Carolina are doing to combat this pandemic. So I'm going to share my screen and chat with you a little bit today about some of the areas that we have tried to touch on since this pandemic hit our state. So the first thing that we decided to do, that we recognized was important when we got our first cases, is we knew we needed solid data to help inform our decisions about how we would reopen our businesses across the state, how we would phase that or not phase that. Our governor likes to talk about a dimmer switch rather than an on and off switch when it comes to opening and closing our state's businesses. And we focused on 4 metrics, and you'll see one of them in the screen down toward the right. The 4 metrics that the governor, the secretary, and key decision makers across the state look at and review on a weekly basis are the number of COVID-like syndromic cases, the number of lab confirmed cases across the state, the number of positive cases as a percentage of total tests, because we recognize the number of tests and completed tests doesn't really give you the clear picture. And so we wanted to look at positive cases as a percentage of those overall tests, as well as the number of hospitalizations that are reported across the state, because we recognize everybody has capacity limits. And so we tried early on through concentrating on PPE and prioritizing some of the needs across our urban areas where we were first seeing this pandemic breakout to make sure that we had the resources directed in the right places. And then we also began to track data. If you see here, this is our map of North Carolina, and North Carolina has 100 counties if you're not familiar with it. And so across the state, we began to track the number of cases, a number of positive cases per 10,000 residents. So we began to create a sort of a heat map. And this is available, this website, I think can be put in the chat to share with you guys if you'd like to go and see what our dashboard looks like. It's interactive for the public. You can hover over a county, and even though my screen is static, if you go onto the website, you can hover over a county and see the number of cases and the number of deaths. You can drill down as well and below, a little bit below on that page, and if you know a zip code that you're interested in, you can also type in that zip code, and you can compare zip codes across the state as well. So it's a nice interactive map, and it was certainly a data point for us to use as we made decisions about how to direct funding. So this kind of shows you how we've been tracking incidents of COVID as they have presented themselves across the state. And you can see North Carolina is still a highly agrarian state, agricultural state, and so we rely heavily on our migrant farm worker population, our migrant and seasonal farm workers and growers across the state to help get one of our highest money-making industries continuing to grow. And so unfortunately, we have seen a lot of hotspots come up in cases where we have concentrated numbers of people, either through farming or through some of our meatpacking industries and some of our larger concentrated work sites. So there's the data. So what did we do? Well, North Carolina, our General Assembly passed Session Law 2020-4, which we know as the COVID-19 Recovery Act or the Coronavirus Relief Fund. And lots of money has come in through the federal government, through North Carolina, to lots of different departments across the state. And I will talk a little bit about what we in the department have been using these funds to target. But I do want to show, and this is probably not different from other states, but we're in a tight time frame to not only get the money, make sure that we have the right resources and we have the right focus, but that we get it spent by December 30th. So we're really under a crush. But as a department, we decided to focus on three main areas of support: testing and contact tracing, coordination and referral, which I'll talk a little bit more at length because that's the area where the Office of Rural Health has been most closely involved, and isolation and quarantine supports. And these three really do flow together. They don't live in isolation, although some of the funding is definitely targeted for each of those areas. We have been, with coordination and referral efforts, we decided that we would best be able to quickly deploy resources using a workforce that is already in place across the state, probably a little bit informally than than we probably would like, but community health workers. Community health workers are in every county in our state. They are heavily invested in their communities. They're members of their communities. They recognize the needs of their communities. They're culturally and linguistically aligned with these communities, so they know where the needs are. We put forth a competitive RFP and last week awarded 7 organizations that you'll see here across 50 counties in our state. And if you go back and look at that map, the hotspot map, you can see it fairly mirrors what the needs are in those darker counties. And so for these 7 vendors or organizations, they're going to hire 327 community health workers and work in these counties across the state. Community health workers in a glance, this is a little bit of a messy flow chart, but it does speak to the overall idea of how we are trying to use community health workers to help folks who are either quarantined or in isolation or who need to be tested. So this is a nice busy framework, but it shows you how we are linking not only the testing and the tracing, but the community health workers will get referrals from these individuals from local health departments. I know these are a lot of acronyms. So local health departments, community-based organizations, primary care practices, outreach workers, even individuals may recognize a community health worker and say, I don't feel comfortable going to the local health department, but I don't feel well. I need to talk to you about my symptoms. I understand you have some available resources you can help me with. And so using the community health worker model, the community health worker will triage the needs based on how these individuals come to them and their workloads. And then they'll use some of the tools that we've set up in our state. We have a really innovative platform called CHER 360. And I believe that website can also be shared in the chat. CHER 360 is the first of its kind, as far as I know, that can link individuals through referrals from primary care doctors to some non-clinical drivers of health. And right now it's focusing on transportation, housing, food. And so CHER 360 is a platform that community health workers will use. They're going to be equipped with iPads or tablets or laptops, as well as hotspots or a little Wi-Fi, so that they can go out and make sure that that internet service is not a barrier to care. And using CHER 360, they can help connect individuals with those resources. And we're tracking the number of referrals that are made, as well as what we call closed loop referrals, which is when a person not only is referred to a resource, but actually makes that connection. So if an individual goes and gets the food that's required because they don't have enough to see them through the quarantine phase, or they're connected with a housing resource because they need to isolate and they can't do so in their environment. So documentation is going to be important to track how effective we are using these tools. Check My Symptoms and Find My Testing Place are two DHHS links that can help individuals who, again, maybe don't feel well and they want to see if they need to be tested. So there's a quick series of questions that the individual can answer. It's in Spanish and in English, and depending on the result of that, if this individual would like to be tested, the community health worker can help that individual find a test site so that he or she can be tested. Then, of course, the beauty of this is connecting the person to the resources that are needed. So once, hopefully, we will be able to do that successfully, or hand them off to someone or a primary care provider or someone who can further assist them if that resource is not met directly through help with the community health worker. And we're also working with our behavioral health partners if there are behavioral health needs that are certainly outside the scope of what the community health workers can refer. This is an overlay of a map that, because we also want to connect, as I mentioned before, individuals to primary care providers. These are the primary care or safety net sites across the counties where we have these contracts, so that the community health workers can readily have a resource for connecting an individual to a primary care home. And because testing this map is probably a little bit difficult to see, it looks very light, but this is an overlay of health departments that are in those affected counties. And so because the local health departments are tasked with reporting cases, we always have to link back to our partners in the local health departments. So I'm going to pause there and stop sharing my screen and pass it back to Al.
Thank you. I was quickly posting there. Thank you, Allison. Our next guest is Norma Marty. And Norma, I want to welcome you to our call today. Norma is with the North Carolina Department of Health and Human Services and has an extensive experience as a bilingual bicultural person. I'm getting a little feedback, so Her focus is on engaging historically marginalized populations with resources and healthcare, and she has conducted hundreds of grassroots presentations. She has over 20 years of experience with training for and supervision of both qualitative and quantitative data collection methodologies, as well as translation and interpretation of survey instruments in both English and Spanish. Norma, we're really glad to have you this afternoon, and we are looking forward to your unique perspective about the impact of COVID-19 in rural communities.
Thanks, Al. I really appreciate being part of this webinar today to, again, bring in at least the perspective or the 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 view from where the Latino, Latinx, Hispanic community is in the state of North Carolina. Let me share my screen. Hopefully I can do this correctly. Oops, what? So, okay, so again, focusing particularly on the Latinx community, but feel free to ask questions or put something in the chat and we'll try to get back to you. So what we found in the department, I've been with the department, well, on and off for the last 15 years. And so during COVID, I was asked to come in and work in the office of the secretary to help address that kind of, I like to call it a community health worker role, connecting the department to the community and the community to the department. And initially, by June, we were looking at the numbers increasing in North Carolina in terms of COVID positive, and particularly within the Latino, the Latinx community. The numbers were really, really disproportionate. We're only about 10% of the state's population, but yet up to 45% of the positive cases, confirmed positive cases, were coming from the Latinx Hispanic community. And so the secretary said, we've got to do something. We've got to do something. What are we going to do? And from the beginning, the department has two things I think that have really been unique maybe to North Carolina. And again, I'm really proud that we've taken those steps. And that was, the decision was made that anything and everything is always provided in English and in Spanish. So even when the governor and the secretary have their press briefings, there is a Spanish simultaneous translation going on at the same time that can be plugged into any stations or any television or listened to online by anyone in Spanish real time. And then anything and everything that was developed in terms of public information, communications, media has also been translated into and made available on our website. So from the beginning, we realized that had something that we had to do. And then in addition to that, the department has established these work streams of historically marginalized populations. And the 5 work streams focus on, again, populations that across the state may not be as equitably receiving of the services that the state may have to offer. So of course, the traditional African American, American Indian, Latinx, which is more of a relatively newer population in the last maybe 20 to 30 years in the state, LGBTQ, refugee and immigrant population. So again, bringing all of those community leaders to the table to look at what we can do. So the initial concept was, let's increase knowledge of prevention. So wearing the masks and six feet distancing, 2 metros if you're going to communicate to folk in Spanish, and testing availability, where you can go, where what's the cost, where what do you need to bring, and then again contact support, which is some of what Allison was sharing, coming out of the Office of Rural Health and other parts of the department. So within those historically marginalized populations, we review and look at everything that's coming through in terms of programmatic initiatives, ideas. We brainstorm, we listen to each other so that we're sure that all the communities are being represented in all of our efforts. And again, my role, of course, is to be the eyes and ears for the Latinx community, making sure that we are, and it's not just me, there's a whole team of people, but just to make sure that we're addressing and communicating to the people on the ground. And again, these numbers were so disproportionate to the population that we immediately realized that it was because we had people, communities, the Latinx community, that were doing the essential work. They were the people in the factories and the people cleaning the hospitals and grocery stores and you name it, daycare centers. A lot of our population could not work from home. So because of that, then those numbers of 45% of the confirmed cases became pretty obvious. So again, by 1st of June, end of May, we granted 5 non-competitive grants to the organizations that you see listed there to the lower left. Amichgan, which works in the eastern part of the state, mostly in rural farm labor areas, counties, not very big urban centers. And Centro Hispano, which is based in Durham, North Carolina, but covers three or more states, is again very involved and has been historically involved. All of these organizations have been on the ground probably for the last 20 or more years as the community has grown. The one in the middle that doesn't have a name is the Latin American Coalition in Charlotte. Charlotte is our biggest hub in terms of infection rates and in terms of infection rates of Latinos particularly. Urban, very urban, and again, what was driving that was more of the construction and growth in that metropolitan area. True Ridge, which is way on the western end of the state, what we sometimes call the forgotten country of North Carolina, because it is rural and it is in the mountains, and so you have to do a lot of it's a 6-hour drive from Raleigh, and here the capital is Raleigh. This is where I'm at. So it's a good 5 or 6 hour drive to get to the very end of the very tip of North Carolina. True Ridge has been working with a lot of our, again, farm worker, that side of the world. We do Christmas trees, apple orchards, a lot of population that are they're year-round as well as come in during the seasons. And then lastly, Que Pasa Newspapers is one of the oldest Spanish language newspapers in the state. Started in the Raleigh Triangle area, moved to Charlotte, has at least 4 other hubs. It's free. It's usually at every tienda, community center, neighborhood, corner, stores. So it was an obvious way to start getting some of the messaging out. So we brought them on board immediately. I think, again, immediately in terms of state contracting and having our monies available from the CARES funding that came through our General Assembly. So they immediately, and had already been on the ground, providing food, providing monetary assistance, rent, paying bills, but granting them an additional amount of dollars to really coordinate that effort through and with their local partners. And so again, just looking at what we've done, again, committed from day one to do everything in Spanish, including when we're talking about contact tracing. We've hired, I want to say 700 plus contact tracers, of which 277 are bilingual, bicultural, Latino, Spanish-speaking folks. Again, we've identified the need for testing. We've ramped up a program specifically for free testing in, again, some of those same communities that you saw on Allison's map of North Carolina, again, looking at density of population that were positive, where there were no other testing sites. The acronym is CHAMPS, and I'll be darned if I can't remember what it stands for, but the basic goal is to make sure that there was testing availability in those rural counties and that there would be no cost. The contract was unique in that it offered only 3 weeks. Again, the vendors had to prove that they were testing 100 people a day in those 3 weeks, and if they did, then they would get another 3-week contract. So we're really, really, really committed to making sure that they just did not get a contract and go to the easy spots. They were committed to, in the contract, to working with the local health departments and with community and faith-based organizations across the counties, or specific zip codes that they were charged to cover. And then as we moved on, again, I'm just kind of a timeline here on the side, you know, the launching of the materials, engaging statewide diagnostic testing, which is the CHER program. We looked at ordering or getting more diagnostic testing reported from all of our local health departments so that we know not only who and what, how many, but also the demographics. So we do have data by race and ethnic origin and age. The priority counties that we immediately identified, if you look there, Mecklenburg is Charlotte, Durham is the Raleigh-Durham area, Wake is the Raleigh-Durham area, Alamance is over toward Greensboro, toward the middle of the state, Guilford, large communities with Forsyth County with a lot of immigrant and newly refugee communities. And then we moved into more rurals, which are Lee, Duplin, and Johnston counties, where we have large farm growing, lots of farm activity and farm workers that come in under H-2A visa for the most part, as well as our migrant streams. And as I said, we identify these five entities to help us. These are, again, community-based organizations, grassroots, been serving and working in the community, are known and respected in those communities, and they have been really taking the lead in identifying who they can partner with and how they can reach the community that needs testing and the support services. So here's what CHAMP stands for: community testing of high priority and marginalized populations. So what it does, it provides, again, increased no-cost testing. 300 temporary testing sites were deployed at no cost to about 100 zip codes that reached about 2.2 million people. And the biggest challenge, of course, within the Latino Latinx community is the fear of deportation, of status checks. And so that's really important that we stress to those communities that we're a health entity, and as such we are not sharing. All the information is confidential and is maintained within our preview, and not something that we share with other departments across the state or across the nation. And again, part of those groups, when you're looking at the names here, Vidant Health, Origin, and the NC Community Health Center Association, are three of the grantees that have been doing all of this testing, again, at no cost to the person coming for a COVID test. And again, as Allison mentioned, we've just awarded a grant to 7 or so organizations that have hired 250 to 300 community health workers. And then we're currently looking at what we're finding is that within the workforce, especially in the rural areas where it's farm and meat packing and meat processing, that we're trying to identify best practices for employee-based outbreaks. How can we quarantine? How can we facilitate? How can we help the growers and the plants maintain the workforce that they need to do the work? Again, it's very seasonal and immediate, sometimes even short term. So, an outbreak can really be devastating to that economy. What we've done so far, we've acquired additional PPEs, about 900,000 were are available to be distributed through. We've been using our emergency management systems across the counties because, again, North Carolina it's a hurricane bearing state. We have emergency management systems across all of our counties, rural as well as urban. And so they have been working with a cooperative extension, our East Coast Migrant Head Start programs, and other migrant health outreach programs to distribute those specifically to farm workers and to factories. we've been developing, as I said earlier, materials in Spanish and continue to do that. We've just launched this week what we're calling, the Secretary has been referring to our prevention as the 3 W's. Wear your mask, wait your 6 feet, and wash your hands, right? And so we've come up with a Spanish equivalent of the 3 M's. So it's, use la mascarilla, manténgase 6 pies de distancia, y lávese las manos. So it's kind of a nice, cooperative translation. We're really excited about it. We have hired a Latinx media firm out of Charlotte that's helping us create all of the messaging across the various different products that we'll be releasing. So both social media as well as print and the traditional TV, radio. I think we've been on 1,000, no, I shouldn't say 1,000, but we've been on a lot of media. A lot of people using Facebook Live. I've been on different panels from 7 o'clock to 8 o'clock, 9 o'clock at night, which really helps because that's when people are home from work. Remembering that, again, for the Latino, Latinx community, they're working. They're not working from home. And again, the media campaign that I mentioned earlier, developing PSAs and doing various different social media hits on both Facebook, and we're exploring WhatsApp, which is a big application that the Latinx community uses, particularly that 30 to 50 year cohort and the Spanish speaking cohort. So it's something we're not very familiar with as a communications effort, but we're really working to learn and try to create something for that world. So here are the links, and I didn't share these with Al's team, but I'm sure they'll be sharing the slides. So all of our tool kits for prevention and protection, in terms of the 3 W's, the 3 M's, everything that we produce can be downloaded and customized with your own local logo, community organization, information address that you may want to have, including, again, the social media toolkit, which will provide you with specifically things that you can push out on Twitter, on Facebook, short little, those quick little bits that help you message quickly but effectively, we hope. And our Division of Mental Health and Developmental Disabilities and Substance Abuse has 2 helplines, and we're talking about mental health issues for rural areas. Again, these are just great old telephones. People can call. You don't need bandwidth, or you don't need to get on the internet. If you really want to talk to somebody about your mental health status, there's 2 places, the Hope NC for everyone, anyone that needs assistance, whether you're a mom, a dad, whether you have substance abuse, whether you have a child with developmental disabilities, that's the number. It's an 855 number. And then they just released the Hope for Healers helpline for the essential workers, the people who are going to work every day, the doctors, the janitors, the grocery store clerks, the people who are not able to disengage because they have to face COVID every day as part of their workday. So the Hope for Healers is a place where all of those essential workers are encouraged to call and seek help and assistance. And in addition to that, I know one of the questions that we had was particularly on the mental health in rural areas. I don't know if this is the right place to say it, or whether we're going to go over all of the questions, but basically the Office of Rural Health has their, just wanted to see our beautiful 3 M's there at the bottom. And that's who I am, and that's how you can reach me. So if you have any questions, I'll be happy to answer. And I'll share the mental health webinar that was done by the Office of Rural Health Farm Worker Health Program about a month ago. That was an amazing I actually cried as I listened in, because these were the outreach workers that are part of the teams in the community, in the federally qualified health centers and grantees done by the Office of Rural Health. They were the ones who, you know, are reaching out to the farm workers and to the folks in the community in rural North Carolina. And the office offered a webinar for them. They had 2 therapists on. It was in Spanish, if that was the language you wanted to use. It was in English, if that was the language you wanted to use. And it was an awesome opportunity for these workers, frontline workers, to be affirmed and to be encouraged to continue doing the hard work that they do every single day. So that's the end of my presentation. And I will, now the challenge is stop share, and hopefully you can see us again.
Thank you so much for those wonderful comments and really highlighting both the issues and one state's approach to COVID-19 in rural communities. And so we had quite a number of questions that registrants asked, and we also have questions in the Q&A box. And I'd ask if our attendees have questions to continue to put them in the Q&A box because it's a little challenging to monitor what's happening on Facebook, in the chat, and also in the Q&A. So if we have them in one place. So Norma, first of all, thank you so much for your comments. Allison and Norma, I wondered if you could talk about this intersectionality. And Norma, you have in your presentation talked about the Latinx community and in rural spaces. But what about other rural communities of color? How should we be thinking about that, particularly in the context of COVID-19 and the unique issues that those communities might face?
Well, I guess I could address a little bit of that, because again, that's the work of the historically marginalized population groups. We have reached out to, particularly for the African American community, really reached out to faith-based communities because they're, in North Carolina at least, they are pretty much the backbone of a lot, if not all, of our communities in rural North Carolina. They have actually all participated in and are asking for testing to be held, either in their parking lots, or again, just partnering with all of our grantees and vendors, trying to make sure that the communities that they serve are being served. And so that's from the African American. I think that's our strongest outreach effort, is within that faith-based community. With the American Indian population, again, we've been working, they've been at the table and in the historically marginalized population work groups. They have, again, we have 8 tribes in North Carolina, in case people don't recognize that. And, 1 federally qualified, the Eastern Band of Cherokee. The others are just state or not have ever been recognized, but are still very much part of communities across the state. And they have all been at the table. They have the Commission on Indian Affairs has been speaking directly with the Secretary to ensure that we're addressing and right now the rise in the American Indian population. That seems to be the numbers that we need to start kind of paying a little more attention to than we have been. In Western North Carolina, our biggest rural concerns are the college students returning, because we have some really not huge like UNC, Chapel Hill, but still a significant number of colleges and universities. Some are state and some are private. And also they're concerned with tourism. You know, Asheville is really a beautiful place to come in the fall on a good year. So they have really been trying to address, how do we message that they can still come, but we want them to be, you know, following the protocol of mask and distancing and hygiene. And so they've created a team, which again, an alliance of a network of not only the AHECs in the area, the area health education groups, but the hospitals, local health departments, and again, the community-based organizations, to try to address those kind of, and again, Western North Carolina really is probably are more, we have the two extremes, the West and the East. The East tends to be most agricultural, rural, and the West tends to be agriculture, but really more touristy. So again, addressing and trying to identify ways to get the message out that they like. Someone mentioned, do we do research? Yes, we've done work on what kind of masks do people, prefer. Duke University has released some findings on that. Again, what we hear from the rural part, the western part of North Carolina, is that they really, really trust their local people. They don't want someone up here or even someone in Raleigh to be on the poster or be talking to them. They want to hear it from that local doctor, that local health department, their faith-based, leaderships. But they're not quite sure that they want to listen to the rest of us that are not necessarily in that space with them. So those are the kinds of things that I think I've learned in the last few months.
Wonderful. I'm going to well, this is for both of you, but Allison, if you wanted to take it first. What is the long-term state sustainability plan when it comes to understanding how to deploy resources more effectively to counter disparities in events of public health crises? So what have we learned from the COVID-19, our annual hurricanes, our recent earthquakes, that creates a sustainable plan in terms of preparedness?
I think two things come to mind, and it's interesting. We had begun our community health worker initiative a couple of years ago in a very targeted way. We piloted some core competency training across some select community colleges to help train this emerging workforce as we see as essential linkages between the health community, the clinical side of the house, and then all those other things that, of course, research has shown really do drive our health status, right? Like we don't have access to clean water, we don't have access to good food, housing. So we had begun these efforts in a very small, kind of deliberate way. And we'd also begun talking about telehealth as a way to level the playing field, if you will, particularly among people in rural areas who may have a primary care doctor, maybe, but to get to that specialist, that oncologist, that dermatologist, would require travel, time away from work. All these barriers began to pop up. So we were dipping our toes into telehealth a little bit, but I think what COVID has done for us is catapult both of those initiatives, and we've really shown that we can affect change in a great way in a small amount of time. And so what we would like to see is sustainability for both of those initiatives, because we think when we look at rural concerns and challenges, we feel those are two ways in which we could probably affect the greatest amount of change in the shortest amount of time. And so barriers to those, of course, are, I will say in a word, reimbursement, because telehealth is not reimbursed uniformly across payers, and community health workers are not reimbursed uniformly across payers. And so we're working on initiatives like that, or I think, not being an advocate, in the state we can't advocate, but we can certainly show through evidence that these things are beneficial and can really help solve some of the problems that have been in place for rural residents for many years.
Right. Yeah, there's not much I can add to that. I think one thing that I have seen working every time we ask the question of, what's going to happen after December, everyone's asking that question and trying to identify ways that whatever we create for COVID is something that might be possibly sustainable beyond COVID. Things like isolation housing in counties where there are no hotels or motels. What alternative housing is possible? Because it's not, again, we're a hurricane state, so it's not just a national pandemic, but also when we have whatever, the hurricane, the tornado, the earthquake, we had all of those things last week. And so how do you create spaces in those rural areas that can move people to a safe location until they can get back to their home. And we all know that, you know, hurricanes take years before folks can actually get back to their normalcy. And I think that's the question we keep asking ourselves as we look and plan for now. How are we dealing with COVID? How can this help us in the next whatever crisis stage? And so looking at funding, trying to be creative, partnering, you know, with the local local emergency management teams, just, you know, the labor, art, commerce, working with the Growers Association, again, just trying to get everybody to think kind of broadly.
Mm-hmm. So there's a question in the Q&A box about what advice would you give, or what kinds of tips would you share for people from other states out in the South that are wanting to implement some of these initiatives in their communities?
I believe a good conversation is a great start. We recognize even within our department, there are so many different wonderful initiatives taking place, but we have to talk to each other to make sure that not only are we aware, but we can help each other. And I think reaching out and being present in communities, one of the things that we in the Office of Rural Health really pride ourselves on is our partnerships with, we give out a lot of grant funding, but we don't consider ourselves, you know, the big taskmasters. We really look at communities and rural health providers as our partners, because they are the way that our mission is achieved. And so I think recognizing, finding the resources or identifying the resources, and then having a conversation and an honest conversation, and not starting out with, I think this works best for this community. It really ought to be from the community, with the community, and then state agencies or county agencies can really be more in a facilitative space rather than a directive space.
Right.
Mm-hmm.
Yeah, the bottom up concept. I've seen it work just during COVID. I've seen it work many times, but specifically during COVID, you know, one of the grantees that we gave money to has been convening the county local health departments weekly. You know, what are you doing? How are you doing it? What can we do to help you? And then everybody else in those communities has started coming to those meetings to learn about what's being done and how it's being done and what they can contribute to that need. And it's been really, really wonderful to see. Something that should have been happening always, but it's happening now. And I think, again, that communications, that letting people come together, as a state, again, on the bureaucratic side, you know, making some monies available so those things can happen. You know, it doesn't have to be a big pot of money. It doesn't have to be millions of dollars. It'd be nice, but it could be a small pot of money that people could use kind of to springboard and help coordinate. And again, you know, every state is different. Even within our state, everything is different. You know, with the West and the East are very different than the Piedmont, the central area. And so letting them have a voice on how all of the initiatives take place. Everything that we have is on our COVID-19 website at the state. So feel free to look at, and you know, if you have questions, of course, reach out.
Norma, Allison, you really highlight the innovation that's actually occurring in rural communities, because oftentimes people think of rural communities really from a deficit perspective. But what I'm hearing today is kind of something very different. What do you think about that in terms of, again, how do we move forward from this moment, Norma, that you're talking about to facilitate sustainability? What additional ideas would you offer those who are working in rural communities?
I think rural communities are well connected with each other. At least that's been my experience growing up in a rural town in southeastern North Carolina. Everybody knows everybody, and they know each other's business, whether you like it or not. And so I feel like the challenge is you know the problems at this level, but you may not necessarily have the connections with those resources that Norma was describing, and you may not have the connections with people who can help facilitate those things. And so I think if the boots on the ground, the well-connected folks can, again, find out who are the resources I need to link with, start maybe at the county level and work the way up. But it is always interesting to me when there's this play of local communities know their challenges and probably know the solutions, they just need some help, versus at the state level trying to prescribe something that will be far-reaching, that could help a lot of people. So I think finding that right balance and using the knowledge on the ground. I think the community health worker model is a really great example of that. The organizations that we contracted with are large and they're regional, but they're not doing the work at that level. The work is happening locally, and they're already connected at the local level with those organizations and individuals, and a lot of them through the faith-based organizations that Norma was describing. So it's to me, it's about connecting those resources locally and then more broadly where there's need.
Yep. And health systems really in North Carolina, and again, maybe it's different in other states, but we have, again, the regional health systems. Some are private, some are public, but they are very much present. And when they open the door, when they get the money and then they share it with their communities, it really does go a long way. And I think the next cycle that we're going to in terms of granting, which is for isolation and housing and wraparound services for folks that need them, that RFP went out ended last week, and selection is this week. The people that are bidding are the well-established large entities that already are well-oiled and have funding to do what they do, but they can actually administer this grant by making sure that those really small church-based, just small 501(c)(3)s who maybe just have a small portion of the county, they don't really serve everybody, but just this area where the meat packing plant is, or this area where the farm workers, or these 2 trailer parks that all of the community lives in. So they don't have the ability to write a proposal for the state to grant them money, but if that entity that does is required to partner with those as part of the grant, then they can share the resources, and then the people on the ground, they're going to be delivering the food, transporting the person, checking in on them to make sure that they're getting better, or making sure they go to the hospital if they need to. They can also not just do the work, but also be compensated for the work. Again, the community health worker model is that. It's always been that. We've called them lots of different things, but they've never been compensated. And that's part of that model that, we're not unique in North Carolina. Other states have championed it, New York and Massachusetts, Texas, even South Carolina has a wonderful community health, shouldn't say just even, but our neighbors to the south have a wonderful community health worker system built into their health provider networks. And so I think paid, and again, keeping the boots on the ground, folk engaged in the work that's being done as it cycles through the granting, which would be the state or the county governments or federal governments directly. So letting people come to the table is the first step.
Allison, Norma, thank you so much. It's obvious that you love North Carolina, that you love rural communities, and I just want to thank you for joining us. We continue to get questions in the chat box, and we'll try to respond to some of those. I think, Norma, particularly, you highlighted opportunities for partnerships, opportunities to facilitate collaborations and partnerships between faith-based organizations, community-based organizations, and the government as well. What we've heard this afternoon is an amazing example of how one state is responding. Norma has provided you with her contact information. We'll make sure that you also have Allison's contact information with the Office of Rural Health. Please follow up with them. These, you talked about a resource. These are resources that are available to you. We are so thankful again for you joining us this afternoon for our webinar series. Last time we were together, someone said these were called Wonderful Wednesdays, and I feel better as a result of this experience this afternoon. I feel more encouraged, and that's certainly something that we need. We want to, again, say thank you. We ask that you would actually complete our evaluation. You can just click on this and just download the evaluation. Give us instant feedback. We've heard from some of you with ideas and recommendations for future sessions. We'd love to hear back from you. So keep that feedback coming to us, and we hope to see you in about 2 more weeks. And also, we encourage you to subscribe to CCPH's newsletter and visit our website, the CHER website, as well as the CCPH website. And please make sure that you do all your part to everything that you can to increase the turnout for the census. So please help us to move that forward. Again, thank you and have a wonderful afternoon.